We have a full slate of 5 lectures. We're going to start out with spirituality and just a review, an overview of all the mental health disorders, because this class is depression, anxiety, and mental health counseling. And then introduce dealing with anxiety and depression. Decided I'd at least do a overview of it this lecture series, and then we're going to get a lot deeper the next one. And then the best evidence-based treatment and the proven, lot of research and statistical data shows that the very best treatment for depression and anxiety is cognitive behavioral therapy. And it really ties into Christian formation, discipleship, Christian spirituality, Christian disciplines. And so I've proposed a Christian CBT. Technically, clinically, it's called spiritually oriented cognitive behavioral therapy. So we'll share that the second lecture. The third lecture, we're going to go through some ethical issues, and then how to interview, how to sort of get an assessment, how to do a broad biopsychosocial analysis assessment so that you can really zero in on the root problem. And then we'll take a lunch break, and then the afternoon, saving the best for last, some understanding skills and helping skills. I figured by that time, I'll want to do something fun, you'll want to do something fun, a little easier, less technical, but very, very practical and interesting. And so that's my carrot out there for you. You know, every once in a while people get tired and they need to go home, but you can't go home till it's over, because this is the good stuff. All right? So let's start with a prayer and we'll dive in here. Let's pray. God and Father, thank you so much for this morning. Thank you for each of these students, and thank you for this school. Thank you, Father, for the impact around the world. I pray that you bless the students that are in faraway places. Thank you for their commitment to learn. Thank you for their desire to help people. And pray that you bless us all and that we could have a very fruitful, meaningful time today. And we feel your presence. We feel your blessing. We love you, Lord, with all our hearts. In Christ's name we pray. Amen. All right. So dealing with depression. We know the verse in Jeremiah, God has plans for us. People need that hope. They need to sense that there is a higher power, and he cares personally for each and every individual, and he has a plan and destiny, and things can work together, Romans 8:28, for the good in their life. All right? A broad definition of spirituality, often used in broader secular circles and hospital chaplaincy, as well as Christian counseling. Spirituality is the emphasis of experiences related to the transcendence or divinity and the search for the sacred or God. Okay, that's a very broad definition that's useful. It's an umbrella that encompasses all kinds of spirituality. Obviously, we're more focused on Christian spirituality. Counseling is a professional relationship, and even I want us as pastoral counselors to look at ourselves as professional. You start getting casual and loose and not following good structure or protocol, I'll call it, then you could hurt people. People can be damaged. And so I want there to be this level of professionalism. And that's one of the compliments I got when I moved to my church in Antelope Valley. We have a lot of NASA engineers and people that are doing high-level research and real brains. And one of them is one of our deacons. He's the treasurer of our board, and he doesn't say much. And then one day he just stopped me in fellowship, and he said, you know, I'm so glad you're here. You just bring professionalism to the ministry. And so I flushed that out. What do you mean by that? You know, is that a compliment or not? You know, does that mean I'm distant or? And he meant it as a tremendous compliment. And so I really want all our ministers to conduct themselves as professionals. And part of it is sticking to the script, sticking to protocols, sticking to structure, and to proven things that work. all right, and making the most of time. When you get casual, you don't use your time well and effectively, all right? So counseling is a professional relationship that empowers diverse individuals, families, and groups to accomplish mental health, wellness, and spiritual, educational, and career goals. Christian spirituality, that's what we're most interested in, is the experience of communion, fellowship, relationship, and connection to God, Jesus, and the Holy Spirit. The psychological, spiritual, physical dimensions of a person are separate but interrelated and at times overlapping. And we have to respect that. The systems of the body overlap, okay? We have many different systems, and I'll show you a slide later today on that. But they overlap and they're interrelated and they communicate with each other. And so the same with the spiritual and the mental, emotional, physical, etc. All right, let's do an overview of neurological disorders. You've got to have some vocabulary here. You've got to have an acquaintance with the language of what universally the World Health Organization describes as a mental problem, mental disorder, as well as in the United States, the Diagnostic Statistical Manual number 5 that is used by all mental health professionals to diagnose. All right, so these are this is one of these are the categories. Intellectual neurodevelopment disorders is one of the broad categories, and underneath that is intellectual disability. And some development is normal. One of the key things about this is helping parents not to think all their kids need to be prodigies. And just because they haven't started reading and writing and talking and speaking French at a certain age doesn't mean they're, mentally disabled. And so this takes testing by psychologists, people that are trained in assessment. That's the different categories of mental health practitioners is psychiatrists who prescribe medicine, psychologists that do in-depth analysis and testing and assessment of people, okay? And then all kinds of counselors and therapists, psychotherapists that do professional counseling, and then pastoral counseling that are unlicensed pastoral ministry people, some full-time, some lay people, all right? But intellectual disabilities, that would include dyslexia, a lot of different intellectual disabilities. Global development delay, okay? That means they really are stunted in their development. They're not developing as rapidly. And some of this is from all kinds of things. One cause could be fetal alcohol syndrome, okay? Where because of the alcohol in the brain, it didn't develop fully on time and may never. But they're seeing that through, if you diagnose a lot of these things early and start working with people, the brain is a very powerful thing and has a lot of capacity and isn't overused and can develop different pathways, neurotransmission pathways, and can adjust. It's amazing. People have had brain injuries and a part of their brain's been damaged, and then years later, there's been a detour made in the brain of the neurotransmitters, and things can come back. So, communication disorder, I stuttered as a kid. That's one of them, okay? There's different repeating of words or not being able to pronounce words. There's a lot of different communication disorders, even just not being able to communicate, period, or communicating only at home and not at school or different locations. So different communication disorders. The autism spectrum is a big one, and it needs some good testing. But whether it's our diets, whether it's our environment, whatever, there is a spike in autism in children, and they've blamed it on immunizations. That's not proven. In fact, I doubt it, but that's not my area of expertise. But I get a flu shot every year. I have to work in hospital settings, and I'm fine. But some people, this is spiked. And again, it's a spectrum. There's mild and there's severe. And a lot of counseling has to do with helping families adjust, helping parents realize, okay, this isn't the end of the world. I know some dreams have to be adjusted, but so a lot of it is helping people work through an adjustment, okay? And then attention deficit disorder, this one is probably overdiagnosed. A lot of research has said it's overdiagnosed in England and America, a lot of first world countries, just because of parenting issues, but it's a real thing as well, and you should probably get acquainted with that. You see a lot of that in the church. Okay, a big one is bipolar-related disorders. Bipolar can be bipolar 1 or bipolar 2. Bipolar 1 is you have a cycle. Manic, where people are really up, and then down, depressed. And the depression usually is more extended. The manic, there's certain criteria for that, at least a week at a time. But that's bipolar 1. Bipolar 2 is more the just down. Or I may have those turned around. Okay, and I was going to check with a few of our experts. When you're up here, at this age, you have these brain irregularities. So, but the bipolar 2 is mainly just depression. And guys, let me be emphatic. I'm not going to be emphatic about a lot of things, but if the brain chemistry is low and not balanced and people are depressed, I don't know how many testimonies I've heard from college Christian professors who have bipolar 1 or bipolar 2. They will just, state clearly, you have to have medication to get balanced. I function, I do well. I knew one professor for years before he came into a class and did a testimony about his depression. I had no idea because he's managed it with medication, but he said, without medication, I couldn't function. And so please don't be quick to discourage people to not go on medication. This stuff there's emotion involved in some of it, but there's brain chemistry and neuroscience involved. And people treat when they don't know what they're talking about. You don't know what you don't know. Please don't get out of your scope and don't be telling people. I had a couple in my office Monday night, and their psychiatrist has prescribed something for one of their children, and the mother's just opposed to it and won't let him take it. He wants to take it. He's got this relationship with the psychiatrist. She doesn't believe in it. And some other sister in the church said, no, you don't want your son on that. And I'm like, we're ignoring experts. We don't trust them. And just because we trust someone's spirituality, please, we need to help people to be compliant or to get a different opinion or a second opinion or third opinion if they don't agree with it, but not just be willy-nilly and do whatever, okay? And then depression, we're going to go through that, but the symptoms are real, they're biological as well as emotional, and they've got to last at least 2 weeks. All right, anxiety disorders. The most common is GAD, generalized anxiety disorder, okay? And we'll talk about that. We'll go through specifics of that. Agoraphobia, that's being afraid to get out of your house. That's a social phobia, that you have fear of situations. Maybe claustrophobic in an elevator, a lot of things like that. I have a friend with this that walks the stairs and tries to get hotel rooms on the first or second floor for that reason. Social anxiety disorder, this is, you just start freaking in crowds, and people in our churches have this. And so they sit in the back or they come in late. Don't just judge people that are that way. Some of this stuff isn't even diagnosed. They don't know it, but they know how they feel. And they know whether they can function or not. So this is a big one. And then there's a lot of specific phobias. I'm afraid of heights. I drive over some of the bridges in LA. I grab hold of the steering wheel. I start hyperventilating. My legs get rubbery. My family makes fun of it, and it's not nice. They say, look, Dad's freaking out. Dad's freaking out, and they think it's funny, but I really am. It's a physical phobia. I know it's because my brothers I'm the youngest of 4 boys, used to throw me up and drop me. And so I have this fear of falling. I see myself falling off the bridge. And I don't know if that's true. That's trying to be funny. But anyway, let's just stick to the academics. All right. But there's a lot of fear of spiders, fear of snakes, etc. Panic disorder. This is a real big one. I mean, this mimics a heart attack. Your chest gets tight, your blood pressure rises, you start panicking. It's sort of like the stimulus stress response of danger, where all of a sudden all these systems go off because you have fear. It's the fear response in us. It's a natural biological thing. Your brain kicks it off, but then your body kicks in. And all the blood rushes to your extremities so you can run, all right? And so you have less brain in your head, so you're not thinking as well, and it's an emotional thing, and it's very real, okay? And people that have panic disorder, they can share how real it is. And then some kids have separation anxiety disorder. But this is specified. You got to look at the specific symptoms of this. A lot of people will claim it, but it has to be of a caregiver, a particular caregiver, and it's consistent. It's not, okay, today they have separation anxiety disorder, and then tomorrow, they seem to be fine. No, it doesn't work that way. We all have symptoms of a lot of this stuff. When my wife was years ago going through the DSM and learning all the disorders, she said, Greg, you have them all. I go, yes, but I'm not impaired. And that's the borderline. You can have a lot of symptoms, but you got to have a cluster of them, and I don't have a cluster of them all. I have a lot of obsessive compulsive, but I don't have enough to be labeled disorder, all right? And it doesn't impair me. I got a lot of things. We all have a lot of things. But there aren't disorders. We haven't crossed a threshold, okay? So be careful. We throw this stuff around. He's suffering PTSD. I'm going to tell you what PTSD is about, and most people don't, but the people that do, it's very real, and it's very severe, okay? Trauma and stress disorder. Well, we're getting there. We're right there. Look, I'm ahead of myself. Acute stress disorder. This is long-term. There's adjustment disorder that's more mild, and it can be extended. It's like you get fired and you get down, a death in a family, but you don't have complicated grief, but you are hurting and you need support. Adjustment disorder can be a lot of things due to disruption in your life and loss. But acute is you are physically, you're actively tight and stressed, and it's impairing you, okay, in functioning. Post-traumatic stress disorder, guys, to be labeled this, you have to have gone through a life-threatening incident. So just because you were really wounded emotionally in some way isn't necessarily going to produce post-traumatic stress. Okay, I've gone to churches, and they said, yeah, we had this really brutal minister, and the whole congregation's got PTSD. No, nobody's life was threatened and nobody died, but a child that witnesses a gang shooting, people that go to war and see death, people that see horrific accidents, there's a lot of things, and it produces an emotional fear and triggers, and there's flashbacks, and there's a lot of symptoms, and it can be very well diagnosed, and then there's a need for good treatment. Reactive attachment disorder. Again, this is if you didn't have a good caregiver for the first year of your life, most people have some kind of reactive attachment disorder. This is very common. I have insecure attachment disorder because my parents were worn out by my 3 older brothers. When I came along, they were tired, all right? And so I have symptoms of neglect. Again, not to impairment, but I have symptoms of hypervigilance, of some paranoia, fear, when am I going to get my next meal? Are my needs going to get met? Kids that really suffer maltreatment and neglect, they have very specific symptoms. And there's a lot of people in the church that were maltreated as children or neglected. And I see a lot of this attachment disorder in the church. Dissociative, this is a significant one. This is out of the scope of a lot of therapists' competency to practice. People that dissociate are very ill, okay? And they're dissociating, meaning they're getting out of themselves. It's sort of they're transcending their body. Sometimes they have delusions, sometimes they don't, but everything becomes surreal. And it's their shock mechanism. It's their way of coping with all the stress and all the pain and all the whatever. And it's a break. It's an emotional mental break and going to a different reality, so to speak, dissociating. And you can have a short-term dissociative amnesia. I got a motorcycle wreck as a child. I went off a cliff. I split a helmet. I messed up a motorcycle. Some other bad things happened in that accident. I have amnesia of that event. I've never remembered it. All I know about it is what the police told my parents, okay, and some witnesses there. So you don't know your name, you don't know your identity. Obviously, it came back. I know my name, that kind of thing. But a lot of people have suffered some kind of dissociation, possibly out of a shocking situation. Dissociative identity disorder, this is what we used to call multiple identity disorder. And it's not schizophrenia. A lot of people call multiple identity disorder, that movie Split, schizophrenia. It's not. I'll tell you the difference. But it's dissociative DID is what it's labeled now. And then depersonalization, derealization disorder, again, this is separating yourself from reality. And then there's these somatic disorders and related things, meaning a problem starts in your head and it becomes physical. People cannot have anything biologically wrong but be paralyzed or blind, and it's a very real phenomenon, okay? They're not faking it. I'm going to tell you about faking it, but there is a real disorder, okay? And somatic symptom disorder is when biologically something's not wrong, but there are physical. There's not physical symptoms, but there are symptoms, okay? And illness and anxiety disorder is you are just so deathly afraid. You can't go to a hospital because you think you're going to die. It's a lot of things are incorporated in that. Conversion disorder, I always forget this, and I looked it up this morning even, all right? But it'll come to me in a minute. This is the one where you're blind or paralyzed, but there's not anything wrong with your optical nerve or any of your spinal cord or anything. That's what conversion disorder. It doesn't, conversion, I go to conversion, right? So I'm always thrown off. I know what this means, but I don't know what this means. It's one of those ones, all right? And fictitious disorder, this is, I never say this right, Munchausen's syndrome. This is when a parent makes their kid sick so that they get attention as some great caregiver, okay? Or they fake it themselves. That's when it's not by proxy. It's just a fictitious disorder. They want the attention. So the hypochondriac, okay? Feed and eating disorders, these are very common. Anorexia nervosa is they do not like their body. They see themselves as fat, and they excessively diet and undereat and are malnutrition. And you got to get a doctor involved. You got to collaborate. There's some mental things. There's family system things going on there. This is a very severe thing. And a lot of young women have it because of the pressure of their looks. Bulimia is the binging and purging. You overeat, you feel guilty, and you purge, okay? And so anorexia is just a body image thing, and the bulimia is the binging and purging. Rumination disorder is when you eat stuff that's not food, okay? And then the pica is when you're picking at your hair and pulling your hair out, your eyebrows, and stuff like that. And then binge eating is, it's not necessarily you're purging too, you're just binging, you're just overeating, okay? So, and then sleep-wake disorders, narcolepsy, most people know what that is, where you just fall asleep all of a sudden. Insomnia, you can't get to sleep. Hypersomnolence, disorder, that's when you're sleeping too much. And breathing disorder, sleep apnea, I have it. Used my CPAP last night, every night. You know, that's where you stop breathing. Or chronic snoring is another one. And parasomnia and restless leg, that's a neurological thing, okay? Disruptive impulse control, conduct disorders, these are big things. In teenagers in the church have some of this. All right, kleptomania, they steal, they don't need to, all right? But they get a rush, a joy out of it, getting away with something. Pyromania, they burn things, sometimes out of a comorbid situation where there's a oppositional defiant or conduct disorder too, but sometimes they just like fires and like setting them. Intermittent explosive, this is the person with just the bad temper. It's not constant, it just explodes every once in a while. Conduct disorder is problem with authority. Okay, the operative word there is authority. They rebel against authority. Oppositional defiance disorder, this is a young person that turns into the social disorder later on in life. This is serious, oppositional defiance disorder, ODD. Okay, and a lot of, unfortunately, I don't want to overgeneralize, but sometimes adopted children with attachment issues develop this towards, honestly, their primary caregiver that's doing the most for them. Okay? Substance-related, substance use disorder is, there's a whole list of symptoms, and we'll get into it the next lectures, next time around, some more specifics about this, but it's abusing any drugs. And then alcohol-related, abusing any alcohol and it causing impairment in your life where you're not functioning properly. And specifically intoxication, we know what that is, and withdrawal are the physical things that go on. And usually, if you start having withdrawals, you need hospitalization. You need to go to the emergency room because you can die from them. All right, cannabis-related disorders. Your state's got spikes in this, and so does ours. And I've treated a lot of young people with cannabis disorder, and I have some very strong opinions about it. I think it's all about the money, and it's tragic, and it's going to be a social blight. And it affects brain chemistry, and it's labeled unaddictive. That means you don't have withdrawals, but it is addictive. Okay, it's just this little technicality that something has to produce physical, definitive, medical treatment, and that's when it's called a withdrawal. But marijuana is addictive. It affects your brain. It messes you up. It has long-term consequences, and there's so much propaganda and misinformation about that. It's tragic. All right, inhalant use disorder, that's really big now. Stimulant, that's sniff and glue, stuff like that. Tobacco use disorder, and gambling disorder is a big one. Neurocognitive, these are very important. Delirium is when people go into the hospital and they have short-term just confusion. And it has to get treated. It's very serious, but it can go away quickly. Major neurocognitive disorders like Alzheimer's or Parkinson's and others, and these are on a spectrum and they get severe, and there's got to be some good treatment with psychotropic medication as well as talk therapy. And then the mild neurocognitive disorders is like just starting to get senile, okay, starting to get forgetful. My mom is sort of probably in the mild to moving towards, more serious. She doesn't remember my kids are married. She doesn't remember she's got great grandkids from my children, just different things. But she's happy. So we're fired up about that. Personality disorders. Okay, now don't be labeling me or diagnosing me on this stuff, okay? Antisocial personality disorder. This is the oppositional defiant kid. This is the serious one. This one is the one that sometimes is labeled the psychopath. It used to be. We don't use these labels anymore. We're trying to be nicer and not just cause people to even act out. But this one's a serious one, and it's a disregard it's law breaking. That's one of the things that has to be symptomatic of it. Okay, avoidant personality. This is a loner, borderline personality. These are people that usually have raised by alcoholic parents or in drug addicted parents or something, and suffered some maltreatment, neglect, and they have attachment. They have a cluster of problems, and it produces a real defensiveness, and they have problems with relationship. And these people are very defensive. They're difficult to treat. I've had several clients. I love them, but it takes a lot of patience. There's a certain approach. It's called DBT therapy, dialectical behavior therapy. It's been proven to be the only thing that will help. And so that's a serious one. Dependent personality. This is a person that really is codependent. They cannot make any decisions on their own. Okay? Narcissistic. Again, some of us might have symptoms. Doesn't mean we have narcissistic disorder. Okay, just means we love ourselves too much and we're prideful. But this person is damaging to others. They lack empathy. The world revolves around them. They're very selfish. They're grandiose. It's all about them. Okay, and obsessive compulsive. This is obsessive thoughts and behavior. You have to have both. Okay, I have one or the other at times. So you can't label me with this one, and it doesn't impair me. But my desk has to be neat. Certain things have to be done in a certain way. So I'm obsessive, but I'm not compulsive disordered, okay? I'm just disciplined, I call it, all right? Paranoid personality, this is the person that's more than a loner. They pulled back, and they're afraid of things. This is conspiracy theory kinds of stuff. Schizoid personality, this is also the loner. They want attachment, but they fear rejection desperately. Okay? And then this schizotype is a person that wants connection, but fears it. They're lonely, so they don't try, but they really want it. The other person doesn't even know they have a problem. They're just loners and don't care. Okay, depression, behavioral symptoms. Let's get into some specifics here, because this is what I've been tasked to help you recognize and help people get the treatment they can, and you help them as you have ability and gifts to do it. They're antisocial. They have an irritable mood. Okay, everybody's moody, but this is a persistent thing. They have a decrease in loss of appetite. You've got to have a combination of the physical and the behavioral or mental stuff, emotional stuff. It can't just be they've lost appetite or they're just irritable, okay? It has to be a combination, or it's not really true depression. Diminished interest in things that they found enjoying previously. Their psychomotor agitation and retardation in the sense of they'll fall down, they'll trip, they're not paying attention, they're depressed, they're so sad, they just make mistakes, even in walking, talking, that kind of dropping stuff. Sleeplessness and hypersomnia, they can't sleep as their minds won't shut down and they're so scared or anxious or are depressed, they lack energy, have poor concentration, indecisive, and socially withdrawn. Okay, some behavioral symptoms are they can have suicidal ideation. And guys, anytime somebody mentions hurting themselves, flags need to go up. Tim's going to cover this in his class on crisis counseling. But there's a protocol that you need to be able to recognize the signs. And I'll just tell you the big ones. If they have recurrent suicidal thoughts, suicidal ideation, if they have a plan, and then if they have means and it's lethal, like they're going to take pills, they're going to shoot themselves, they're going to hang. If they have a plan that's that specific and it's lethal, then all bets are off. Call the police, get help. It's called a PET, Psychiatric Emergency Treatment Unit in California, and they'll hospitalize them and keep an eye on them and evaluate them for 72 hours. Don't mess around with suicide, okay? And so they're not just thinking about it. If they are thinking about it, you need to get them surrounded, and some people need to know, and they need to be watched and see if things escalate. If they have thoughts and they have a plan, then you got to get an action plan. You got to get some help. All right? I would get consultation at that point. What do you think? Should we call the PET team? Should we not? And then if there's lethality at all, then you got to do something. You got to be urgent. Okay?
I was just going to say, that's the one thing we need to remember, that is a situation that allows us to break confidentiality.
Exactly. And I'll get into that later. Thanks. And the other key emotion, though, of this suicide stuff is hopelessness. When people are hopeless, that's when they do it. They make emotional decisions, not logical decisions. So hopelessness is another thing you really look for. Okay? And inappropriate guilt, depression manifests itself in low self-esteem, unresolved grief issues, mood-related hallucinations, and delusions, history of chronic or recurrent depression. Okay? And that's labeled something else, and I'll tell you what that is. And then that's cyclically dysthymia is what it is. All right? And then clinical depression symptoms is characterized by the presence of 5 or more of those symptoms for at least 2 weeks. If you have 4, then it's not major depression. If you have 5 or more, it becomes major depression. Depressed moods most of the day, nearly every day, indicated by either subjective report, I feel sad, blue, down in the dumps, empty, and observations by others, markedly diminished interest or pleasure in all or almost all activities every day, such as no interest in hobbies, sports, other things, even taking care of their kids, significant weight loss when not dieting, or weight gain, a change of 5% or more. All right? And then insomnia, inability to sleep, more days than not. There's problems sitting still, including constant restlessness, pacing, picking at one's clothes, etc. All right? And a professional will do a mental status exam on people to see what symptoms are present and how severe this stuff is. And we'll get to that. Fatigue, tiredness, loss of energy, feelings of worthlessness, diminished ability to think and concentrate, recurrent thoughts of death even. All right? Some of the medications. And guys, medication helps. What's proven is some medication and talk therapy. Okay? So please don't be quick to oppose medication. And be careful when people just start self-medicating with marijuana or some of these natural things. There's a lot of talk, discussion, internet chatter, but try to listen to people who know what they know. All right? So a class of antidepressants called selective serotonin reuptake inhibitors, SSRIs. When you get into neuroscience and brain chemistry, this stuff's fascinating, and these drugs work to stimulate the right neurotransmitters that cause the good things in your brain and cause people to have the right moods. All right? But it takes about a month for this stuff to kick in. So they get a pill, it doesn't happen in a week or two, and they have some weird responses to it, and so they think, oh, it's wrong, I'm not going to take it. People, you basically have to get your system saturated with the medication for it to begin to kick in, meaning your tissues have to get filled up. So the bigger or heavier you are, the longer some of these psychotropic medications take to get into your system, and the longer it takes for them to get out of your system. Okay? And so this stuff isn't automatic. There's a lag time, okay, both directions, in taking it and then getting off of it. Recognize and accept, long-term goals: alleviate depressive symptoms and return to previous level of function. That's what we want to try to help people do, okay? Recognize, accept, and cope with feelings of depression. Some things you can't change. You're going to help people adjust and cope, all right? Develop healthy thinking patterns. This stuff comes from somewhere. Depression doesn't just happen. You can trace the sources and start dealing with those particular locations. Develop healthy interpersonal relationships that lead to alleviation, help prevent. People that are depressed don't want to be social, don't want to get out and do things, don't want to serve other people, and yet that's one of the best medicines, okay? Because it starts improving activity, circulation, brain chemistry, everything. So pulling them along and trying to get them to do it is good. Appropriately grieve a loss in order to normalize their emotions. All right? And now a treatment plan, and the last assignment of the whole semester is to come up with a treatment plan for anxiety and depression. And so I'm giving you a lot of help right here, okay? Treatment plans have two things: short-term objectives, and usually you need 3 of those, and then under all short-term objectives, a real disciplined treatment plan. Most people don't do this, but if you really want to be formal, you'd have 3 therapeutic interventions under those objectives to meet them. Okay? I'm not going to give you 3 on all these, but I'm going to just give you a feel for it. So a short-term objective could be describe current and past events with depression, including their impact or functioning. So you want to really assess things. And so then a treatment intervention is encourage the client to share his or her thoughts and feelings of depression, express empathy, build rapport while identifying primary thoughts, cognitive, behavior, interpersonal, and other contributors to depression. So you just listen, you ask the right questions, and you draw it all out. Okay, another intervention is assess current and past mood episodes, get timelines, get scales, sort of ask people, so how do you feel today on 1 to 10? Oh, I feel like a 3. When was the last time you felt like a 5? When was the last time you felt like a 10? So you sort of get a timeline of how things have been going from their perspective. Another intervention, arrange for the administration of an objective assessment instrument. You got to be careful giving assessments, but there's some things that have no limitation. Okay, you don't have to be trained for it. You can get them off the internet. There's some things from that you can just hand out. I think Beck's depression inventory is sort of the standard of therapists, and it's totally available on the internet. You probably shouldn't professionally diagnose with that, but you can get a feel. I give it out with people in my church all the time. I want to see how depressed they are, okay? And it's a very proven, accurate mode, but there's a lot of them out there. There's a lot of stress inventories on the internet you can use. See how stressed somebody is. Another short-term objective, verbalize any history of past or present suicide. Again, always deal with crisis first. Always deal with their well-being first. Assess the client's history of suicidality. If they have a history, then they're more prone to do it and that to occur. Another short-term objective, complete medical evaluation. I send all my new clients to the doctor to get a physical. You got to rule out any biological thing. And guys, a lot of people in the church come for pastoral counseling, and they need to have seen a doctor first. There are some things that doctors can treat, and they really, they can get better, okay? So rule some things out before you spend a lot of time trying to help somebody and then realize, oh, their thyroids are acting up. You know, they have an imbalance in something. All right, TI. Another intervention is refer the client to a physician. I just said that. Another short-term objective, disclose any substance use. They don't like to tell you, especially members of the church, that they've been smoking the wacky or eating the brownies. But that can account for some of these symptoms. No motivation, no mood. So I had a college student that I saw pastorally and even referred her to one of our Christian professionals, and come find out the guy just smoking so much weed. No wonder he is so lethargic and not going to school and depressed. And, you know, I just thought, well, here I know all this, and I got snookered again, all right? So just rule this out. Another short-term objective, provide behavioral, emotional, and attitudinal information. You try to help people become their own therapist. And you try to help people become their own minister. So you're giving them skills, you're giving them tools. People can fix themselves and help themselves. We have strengths and talents. Assist people. Don't do things for people. Assist people. So a lot of psychoeducation, especially if you have smart clients that are just struggling with this stuff, they want to learn how to help themselves. Okay? So psychoeducation is big. Explain things. Tell them all these symptoms. Let them read it from your DSM. I have an app on my phone with the whole DSM. So I don't have to pull out this big intimidating book that I've got all marked up and color-coded. I just pull out my phone and hit it, you know. And I've already diagnosed them. I don't let them tell me, oh, yeah, I have all those symptoms. You know, that's all done with. But then I let them read it and get educated for themselves so that they start helping themselves. Another treatment intervention, assess the client's level of insight towards the presenting problem. You always, first time, you want to find out the presenting problem. Why are they there, and how are you going to help them? Another treatment intervention, assess for the severity of the level of the problem. Then you know, as a pastor, whether you can deal with it or you got to refer to somebody. Stay within your competency, please. Okay? And even me, there's some things I have experience with, I have training for, and then there's some things I'm going to send them to somebody that has more experience and more expertise. Okay? Don't get in over your head. Another treatment intervention, evaluate the client's need and desire for medication. A lot of this, they've had medication before, they didn't like it, but one of our roles as pastors, as ministers, and as counselors is help people be compliant or at least get a second opinion, but not be making professionals' decisions for themselves, because they shouldn't. They're emotional, they're blinded to themselves. And so I help people to be compliant or send them back to their physicians. And I try to get releases so I can talk to the doctor too. All right? And short-term objective, verbalize an accurate understanding of depression. That's that psychoeducation. Another short-term objective, identify and replace thoughts. This is where, and you're going to see in the next lecture, how we do that as Christians, replace these thoughts. This is huge for depression, okay? And conduct cognitive behavioral therapy. Another treatment intervention, facilitate and reinforce the client's shift, all right, in self-talk, learn and implement behavioral strategies. All right, we'll cover more of this. Identify important people in their life, relationships, verbalize and understanding and resolution of the current problem. And for interpersonal disputes, a lot of depression comes from anger. So when people have conflict and it's unresolved, that's the source of their depression. It's a deep-rooted anger down in there. And some of the nicest, sweetest, calmest people are depressed because they really are angry, angry, angry people. And they have unresolved stuff and attitudes and conflicts. It fuels depression. Anger fuels depression. TI, Role transitions can cause, even good ones. I've seen people get promoted, get the job of their dreams, and start drinking because they sabotage them. They blow things up in their mind. The pressure, I'm not going to be able to handle this. I'm not worthy to have this job. And they fall into depression. Good things can happen, bad things can happen. We see it in Elijah, right? The mountaintop experience, and he gets down in the dumps. Learn and implement problem solving. We'll teach how to do that. Learn and implement conflict resolution. We'll teach how to do that. Help the client resolve depression related to interpersonal problems. Learn and implement relapse prevention. Implement mindfulness. This is a big one. It's just staying in the moment and controlling your thoughts. 1 Corinthians, take every thought captive for Christ. All right? Explore experiences from the client's childhood. A lot of times some of this unresolved stuff is back there a ways. Increasingly verbalize hopeful and positive statements. And then some of the diagnostic options are adjustment disorder with depression, bipolar 1, bipolar 2, persistent depressive disorder. That's when it's a year. It's not as severe, but it's over a year. Cyclothymic disorder. Again, that's this long-term thing. And then major depressive disorder, the 4-month thing. So these are all different clinical diagnosis you can use. Major depressive disorder with reoccurrent, schizoaffective, bipolar type, so they're loners, but they have some manic and depression with them. But the mood thing is the big one, and then this other is secondary and schizoaffective. Again, there's a primary and a secondary, and then personality changes, etc. All right? 1 Peter 5, humble yourselves therefore under God's mighty hand, and he'll lift you up because he cares for you. Cast all your anxieties, depression on him. All right? So I'm going to stop there. We'll pick up anxiety in this next session. Okay?